Okay, thank you, Mr. Chairman. Good afternoon. It's always a pleasure to be invited in this meeting. I would like to thank for that. And my topic is entitled Radiological Isolated Syndrome, which I think fits perfectly well after the lecture of the previous speaker. If I can open it. Yeah. Okay. So I will give you some concepts that most of them are in agreement with the previous speakers, some of them maybe not, but we can discuss this at the end of my lecture. And this is the outline of my presentation. First, I will try to give you the definition of what is a radiologically isolated syndrome, the prevalence of this, I would say, rare finding. Also, we can discuss about the diagnostic criteria that have been recently proposed, some prognostic markers from both radiological and clinical point of view, and finally, very briefly, some recommendations about the management of these patients. We all know that according to the McDonald criteria, nowadays we can establish the diagnosis of MS if we could demonstrate the presence of demyelinating lesions disseminated in time and space. And we can do that clinically and in most of the cases using paraclinical investigations such as brain and spinal cord MRI. But we have also to remember that we can only apply this diagnostic criteria in patients who presented some symptoms that can be related to a demyelinating event. So in those patients, if we scan the brain of these patients or the spinal cord, we will see that in up to 2/3 of these patients, we will be able to identify asymptomatic lesions involving the central nervous system. And the presence of these lesions indicate that these patients have previously demyelinating events that probably because they affect non-eloquent areas of the brain did not produce any clinical symptoms. And on the other hand, also the presence of these lesions indicate that the patient has a high risk of developing MS in the next following years. And according to different natural history studies, they show that the median time to conversion, meaning to having a second clinical event, is relatively short. But what about if we, for different reasons, scan a subject in this preclinical phase, where we know that some of them develop these subclinical demyelinating events, and this may happen in patients, for example, with headache or other things, and we can detect these lesions that look like MS. So the definition of a radiological isolated syndrome are those incidental, meaning asymptomatic MR anomalies suggestive of MS that are detected on a brain MRI performed for reasons not related to a demyelinating event. Why now this is having a great importance? That's maybe because there is a high increase in the trends of MR usage around Europe and the States and Asia, and you can see this data coming from this systematic review published recently, and you can see how the trends in the use of MRI is being increased in these 3 different countries. And the indications of MRI in those patients in whom a diagnosis of a radiological isolated syndrome has been established indicates that most of them, the scan was obtained because of headache or trauma. And we have to consider these situations. Also, if we take a look at this paper published 3 years ago, in which these authors analyzed the incidental findings detected on brain MRI, you can see that almost in 0.1% of the patients, they were able to detect inflammatory lesions of the type seen in MS. And this prevalence, as we will see, is quite similar to the prevalence that has been described previously in some pathological studies. This is one of the studies, so this is in the pre-MRI era. This is a study performed in Canada, and they were able to identify 5 cases of unsuspected MS in this number of autopsies, indicating again a prevalence of this subclinical disease in 0.2% of the patients. And you see the coronal views of these patients with the typical MS plaques in the periventricular white matter. So the term radiological isolated syndrome it was first proposed by Okuda in this paper also published a few years ago. And this study was shown the presence of these abnormalities in more than 40 patients. And the most interesting thing of this paper that is the results of other papers is that around 25% of these patients converted to either a clinically isolated syndrome or a definite MS. So these findings have clear clinical relevance. And this is just to show an example. The first case that I could see in our institution, this was a young patient who had a minor head trauma. The Glasgow Coma scale was 15, and this is the CT scan of this patient showing this area of low density in the frontal lobe that was completely unexpected. That's why we performed a brain MRI a few days later, and we could detect these areas of high signal intensity that really looks like MS. We obviously followed this patient from a clinical and radiological point of view, and the patient had his first symptoms only 1 year after this first scan. And this is the follow-up scan obtained a couple of years later with a lot of lesions and even with brain atrophy. So the summary of the definition of radiological isolated syndrome can be that these incidental demyelinating anomalies within the central nervous system are highly suggestive of MS and have been extensively described in several neuropathological studies. Obviously, as I mentioned before, the widespread utilization of MR technology is facilitating the identification of patients or subjects with these anomalies looking like MS. And as I mentioned before, the discovery of these incidental findings has clinical relevance. What about the diagnostic criteria that have been proposed? And these are the ones proposed again by Okuda. I think that these diagnostic criteria are relatively restrictive. He mentioned that we have to consider only those lesions that some of them should be avoided, well circumscribed, high signal intensity on T2, obviously, measuring at least or more than 3 millimeters, and fulfilling the criteria for dissemination in space according to the McDonald criteria. And this is, again, a case where you can see that the patient fulfill at least 2 of the criteria, and therefore fulfill the criteria for dissemination in space according to the 2010 McDonald criteria. But the question is, should we use always the criteria for dissemination in space to define a subject with a radiologically isolated syndrome? And let me show you another example that we had the opportunity to identify recently, and you see that the patient had only 4 lesions, all of them in the preventricular white matter, and if we apply the 2010 McDonald criteria, this patient does not fulfill the criteria for dissemination in space. And according to the criteria proposed by Okuda, we could not classify this patient as a radiologically isolated syndrome. But in my opinion, this patient has a high risk of developing MS because the lesions are very typical for this diagnosis. And in fact, if we, for example, analyzed the CSF in this patient and we detected that the patient had positive oligoclonal bands, and if we apply, for example, the previous McDonald criteria, the 2005 version, we have to remember that they offer the possibility to establish the diagnosis or the criteria for dissemination in space if the patient had 2 or more MRI-detected lesions consistent with MS plus positive CSF analysis. So this patient, in fact, fulfilled the criteria for dissemination in space according to the 2005, but not to the 2010 criteria. So I think that we have not to be too much strict on the criteria and base our diagnosis mainly on the features of the lesions that we see in the brain. About the diagnostic criteria, always we have to remember that these MR abnormalities that we detect in the brain cannot be explained by other diseases, drugs, toxins, vascular disorders, and obviously we have to exclude any historical account for previous clinical symptoms that can be related to these lesions. Obviously, this is quite clear, but we have to remember, for example, this paper that in up to 1/3 of patients with a diagnosis of a clinically isolated syndrome, in 1/3 of these patients, if you make a careful clinical examination and a careful analysis of the clinical history of these patients in fact have previous symptoms suggestive of CNS demyelination. So this means that to establish a diagnosis of a radiologically isolated syndrome is mandatory to collect the clinical history in a careful way. We also have to make a good clinical examination just to exclude the presence of some signs of dysfunction of the central nervous system. It's quite useful to include a paraclinical examination beside MRI, such as, for example, analysis of the CSF, and an extensive differential diagnosis is mandatory in order to exclude other causes that may produce these the radiological findings. And I can recommend this paper published in Lancet Neurology some years ago that review the differential diagnosis of MS based mainly on MRI findings. Also, we have to remember that incidental focal white matter lesions are quite common in the young population, meaning adult subjects between 18 and 50 years of age. For example, the prevalence of MS in general is around less than 0.1% in this age group, and the presence of focal white matter lesions, the so-called incidental white matter lesions, even in this age group is quite high. Some series indicate that up to 10% of these subjects may demonstrate lesions in the white matter. These incidental lesions usually are small, less than 3 to 5 millimeters, mainly are located in the subcortical frontal white matter. Some studies indicated that these lesions are stable over time. They have a very weak association with vascular risk factors, and also it has been demonstrated that these lesions, the prevalence of these lesions increased to up to 40% in patients with chronic migraine. So we have to consider that these incidental lesions not related to MS are far more common than a radiologically isolated syndrome. So which is the diagnostic strategy that we have to apply in our clinical practice whenever we see a patient with focal white matter lesions, and if we consider the possibility that we are dealing with a radiologically isolated syndrome? Obviously, we have to consider demographic data, clinical data, lab findings, as I mentioned before, and also, obviously, we are radiologists. We have to consider the full range of imaging abnormalities that can help us to make a confident diagnosis of a demyelinating lesion. We have to consider, obviously, the distribution of the lesions, also the shape of the lesions, the signal pattern, and the involvement of specific structures that obviously will help us to make a differential diagnosis between MS-like lesions and other type of lesions. About the topography, it's interesting, this paper by Nicola De Stefano showing that the distribution of the lesions that we have seen in patients with a radiologically isolated syndrome match almost perfectly the topography of the lesions that are seen in patients with a relapsing remitting form of MS. So mainly these lesions involve the periventricular white matter and also the body of the corpus callosum. So this is for example, this is a nice example, again, of a radiologically isolated syndrome that we observed a couple of years ago with these lesions in the periventricular white matter involving the corpus callosum, completely different from this other patient, a migraine patient in which the lesions involve mainly the subcortical frontal white matter, and we see that the corpus callosum is not involved. Again, it's very useful in those patients to obtain a sagittal T2 flare. And these are two different patients with a radiological isolated syndrome. You see the small lesions typically involving the inferior margin of the corpus callosum, which are normally not present in patients with migraine and focal white matter lesions involving the white matter. Also, it's very useful to assess the presence of lesions in the so-called juxtacortical white matter. And again, this is a patient that we classify as a radiological isolated syndrome. You see that both on flare and on this inversion recovery T1 weighted sequence, we see this lesion that involves the juxtacortical white matter, while it's almost never occurred this finding in patients with other type of incidental findings, particularly in migraine patients, in which we may see some subcortical lesions, but if we take a look carefully to the location of the lesion, you will see that it does not involve the juxtacortical fibers. And finally, it's also very useful to identify lesions involving the cortical gray matter. For that, it's very useful to use double inversion recovery sequences because it increases the sensitivity of MRI in detecting this type of lesions. And there are a paper by the group of Siena showing that in around 40% of radiologically isolated subjects, syndrome subjects, show this type of intracortical lesions that are mainly located in the frontal and temporal lobes. So again, the detection of this type of lesions increase the confidence for the attribution of these abnormalities to a demyelinating disease. Also, we can assess the signal changes related to these lesions, and these are recent data performed in our institution showing that in most of patients with a radiologically isolated syndrome, if you perform an SWI sequence, at least 50% of the lesions will show these areas of low single intensity with different patterns, likely related to the presence of iron inside the lesions, while this finding is absent in patients with focal white matter lesions related to in patients with migraine. And this is again the patient I showed you before with these subcortical lesions, and any of them show these areas of low single intensity as described in patients with a radiologically isolated syndrome. Also, it's very useful to perform a spinal cord MRI in those patients. Also, again, there are some papers indicating that the presence of lesions in the spinal cord in these subjects is relatively high, up to 30% of the patients, which is quite similar to the prevalence that has been described in patients with a clinically isolated syndrome. Obviously, this prevalence is much lower compared to the prevalence of spinal cord lesions in patients with established MS that can be as high as 90%. But therefore, it's very important to obtain a spinal cord MRI in those patients, and these are the results, again, from the group of Okuda, showing that 35% of patients with this syndrome show lesions in the spinal cord. And the most important finding is that almost 90% of those patients presenting these spinal cord lesions will progress clinically to a clinically isolated syndrome or to MS in the next few years. So this is a very important prognostic factor. So just to sum up about the radiological features that can help us to differentiate between asymptomatic lesions, for example, in patients with headache, from a real radiologically isolated syndrome. We have to assess the topography of the lesions, the shape, the involvement of specific structures, such as the corpus callosum, the U fibers, the cortical gray matter. Also, as I mentioned, it's very useful to include a spinal cord MRI, at least of the cervical segment, because, as in this case, we can detect, obviously, an asymptomatic lesion in the spinal cord. And also, if you have the possibility to include a SWI sequence in order to see if the lesions show these areas of low single intensity, likely reflecting the presence of iron. And therefore, we classify this patient as a radiologically isolated syndrome. And this is exactly the opposite in this other patient, in which the lesions involve mainly the subcortical frontal white matter. There is no involvement of the corpus callosum, of the U fibers, no intracortical lesions, and no iron content on SWI, and also no spinal cord lesions. So these type of lesions that are usually located in this region with a size less than 5 millimeters in size, non-confluent, usually you can define this as incidental findings, probably not clinically relevant, even in young subjects. These are the results of a systematic review that we undertook in our center a few years ago, and showing that those patients with a definite diagnosis of a radiologically isolated syndrome, up to 1/3 of these patients will convert to a clinical definite MS in a period of time between 2 to 5 years, indicating again that these findings have clinical relevance. So just to sum up, the predictors for progression, I think one of the most important is the presence or detection of spinal cord lesions, particularly at the cervical segment. Also, it has been shown that the younger the patient or the subject increases the risk for progression. Also, male have a higher risk of progression, the presence of infratentorial lesions, the number of the lesions, the presence of gadolinium-enhancing lesions at baseline, and also it's very important if you detect new enhancing lesions in the follow-up, also the new T2 lesions, and lab and neurophysiological findings also may help us to suggest the diagnosis and to mention the higher risk of progression to an MS or a clinically isolated syndrome. These are data recently published again by the group of CUDA in a multicenter study that was taken in the US and in Europe that had the opportunity to collect more than 450 patients, and again showing that the risk of conversion to MS is quite high in the first 5 years, up to 34%. And again, this study showed that the presence of spinal cord lesions significantly increased the risk of progression in this population. And again, if you, for example, consider not only the presence of spinal cord lesions, but the age and the gender of the subjects, as you can see in this curve, you will see that if you fulfill the three criteria, the three prognostic criteria, 100 of the patients will convert to MS in a short period of time, although the number of subjects that fulfill these three criteria are relatively low. Also, you can use some more advanced techniques in order to distinguish those patients with a higher risk of progression to MS from those with a lower risk of conversion. And you can use, for example, the brain volume or the MTR values of the white matter. And according to this study, you can really stratify or classify those patients with a low risk, depending on these values, of converting to MS from those with a high risk of converting to MS. And you can see in this graph the nice delineation of these two groups, that in fact those patients with a radiological isolated syndrome that converted to MS have very similar findings to those compared to patients with a definite diagnosis of a relapsing remitting MS. So just to finish, what about the management options? There are several options. The first one is to adopt an wait-and-see policy, and the reason for that is that still, despite we can use different features, radiological and lab features, to establish a correct differential diagnosis, the potential for misdiagnosis is still relatively high. Also, there is a higher probability that these patients, in fact, despite having MS, do have a benign course of MS, and therefore this policy is just to do nothing and wait until the patient, if it happens to have new symptoms in the next following years. The second option is to establish a systematic workup, including spinal MRI, as mentioned. Also, we may consider to obtain non-conventional techniques for assessing, for example, the brain volume. Lab assessment is relatively important, CSF analysis, in order to see if the patient has oligoclonal bands in the CSF. And a follow-up scan, mainly of the brain, also can help us, because the presence of new T2 or new enhancing lesions also significantly increase the prognosis, the risk of developing MS in the next few years. And what about the treatment? It's not clear if we have to treat these patients with different disease-modifying treatments. And in fact, if we review the literature, and this is data coming from this systematic review, indicating that 10% of the reported patients or subjects with a radiological isolated syndrome are being treated in some places. Although there is not evidence that support treatment in this population. However, we may consider that depending on the results of the MRI or the lab, we can help, this data can help us to stratify the patients, not only to make an accurate differential diagnosis, but also to stratify those patients with a high from those with a low risk of developing MS. And therefore, in some circumstances, mainly if we can demonstrate the presence of new T2 lesions, we can consider the treatment of these patients despite not having any clinical symptom. So let me conclude by saying that the widespread use of MRI is facilitating the identification of individuals with brain anomalies suggestive of MS. The diagnosis is based, obviously, on brain or spinal cord MRI, but the diagnosis implies a careful clinical history, clinical examination, and extensive differential diagnosis in order to avoid any overdiagnosis of this condition. Also, we know that 1/3 of these subjects will convert to clinically MS within the next 5 years, and this is going to be more likely if we demonstrate the presence of cervical cord lesions. Although other features also can be helpful, such as the presence of cortical lesions, gadolinium-enhancing lesions, or new T2 lesions. And finally, about 10% of these subjects are being treated with different disease-modifying treatments, although there is no evidence supporting the treatment of these patients. And obviously, further studies are required to fully understand the history of the subjects presenting with this syndrome, and this probably will facilitate us the follow-up and treatment of these patients. Thank you very much.